Hello, and welcome back to CommonHealth, listeners. This, as you know, this is a podcast that we have put together for you all in hopes that we could just bring an everyday voice to the table and you can learn from various folks out here as we continue to do what we do here in the state of Virginia. And so that being said, you know who I am, listeners, but I'm going to tell you again, my name is Tracy Douglas, and I'm the host of this CommonHealth podcast. And I know you hear this every time from me, listeners, when it comes to the guests that we have. And as you know, I do whatever I can to get you the best voice out there so that you can take that information and use it for your own benefit in the world for which you live in. And we know we've got many listeners out there, not just in the United States, but across the world. And we thank you for those that do hear and listen to our wonderful podcasts. But for those of you, I need to bring you up to speed, listeners, on some things. I don't know if you've heard, but we've had a big, beautiful bill that has passed here in this country. And that being said, I really felt it was important that we brought some voices to this particular show around the one big beautiful bill as it pertains to individuals that live in specific areas of the United States that get their healthcare services from what we call, as you know, listeners, federally qualified health centers. So today I'm going to introduce you to this fabulous team. This team is made up of, including myself, but I'm going to put myself aside. It includes 4 fabulous women that represent organizations like the organization that brings you CommonHealth for the last few years now. It is what we call primary care associations. And so with that, listeners, I'm actually going to introduce you to these women. First, we have Sherri Ferrell, who is the president and CEO of the West Virginia Primary Care Association. We have Nora Hoban, is the CEO of the Mid-Atlantic Association of Community Health Centers, which serves 2 states, that's Maryland and Delaware. We have Ruth Pollard, who is the president and CEO of the District of Columbia Primary Care Association. And we have Shelley, who is the president and CEO of the Pennsylvania Association of Community Health Centers. So ladies, welcome to CommonHealth.
Thank you.
Thank you. So we're going to have a really good conversation today. First of all, listeners, I know these ladies. I've worked with these ladies. And again, I had to bring them to you. So that you can learn and hear from them on some of the things that they're doing in their respective states, but then also how some of the political environment, if you will, is impacting the community health centers and their patients in these particular states. But before we do that, I want to break it down a little bit, and I want the listeners to learn just a little bit about each of these women and why they are where they are and how long they've been there. So Nora, I want to start with you. Nora, tell our listeners a little bit about yourself.
Sure. Thank you so much for having us all together, Tracy. It's going to be a fun day. A little bit about myself. I've been at the association now for 5 years. It has been such a ride. I came from the federal government, CMS and GAO in particular, did some private sector consulting work, and also worked for the Maryland Hospital Association. But in my heart of hearts, I always wanted to work either for or on behalf of providers. And I couldn't think of any better provider to work on behalf of than our federally qualified health centers. Just by their nature of being servant leaders that they are, it's just a privilege. So thank you so much, Tracy.
Awesome. Thank you, Nora. Shelley, tell us a little bit about you.
Thank you so much, Tracy. And thank you so much for the pleasure of being here with these talented women and these wonderful PCAs. I'm Shelley Reiser. I've been at the PCA just for a year now. I started July 1st of last year, but this is really passion work for me. I have been a clinician for 34 years. So I have been from the bedside to the boardroom, and to be able to make that difference, having been a former health center COO and acting CEO, this really gives me the opportunity at a statewide, national level to make that impact that we're all searching for.
Awesome. Ruth.
Hello, and thank you, Tracy. Yes, it is such a pleasure to be here with this dynamic group of women and all of your listeners. Ruth Pollard, I am really excited just to be able to bring and serve the District of Columbia federally qualified health centers. I come from healthcare background, the business of healthcare, mostly in acute care, government relations, and strategy. And so I really come to this work with a passion for helping to support our community health centers in the business of what they do. Thank you for having me.
Thank you, Ruth. And Sherri.
Thank you. Thank you. I appreciate the opportunity to join all of my colleagues from across Region 3 today on this call. My name is Sherri Ferrell, and I have been with the West Virginia Primary Care Association for a little over 20 years. I do not have a typical path into the community health center system. I have a finance and business accounting background. I was in public accounting for over a decade, was introduced to this work and realized how much it aligned with the core of who I am. And I have never looked back. So I appreciate the opportunity to be here and to have a great conversation with you all.
Awesome. Awesome. All right, ladies. Now, this is where we need to have you all help educate me as well as the listeners on your respective states, right? And so I'd like to hear from each of you, and we'll kind of do it in the order that we did on introductions. But can you all just speak a little bit about your respective states? Talk to us about the community health centers, how many you have in your state, how many patients are they seeing on average? And then maybe just give us a little bit of snippet of something that really kind of is unique about your state and those health centers. And Nora, I know you said you represent really 2 states now. So we want to hear about Maryland and Delaware. So can you just give us a little bit of give us those gems about your health centers and the patients they serve?
Absolutely. So I'll give you the data points for each state and kind of just go back and forth a little bit. So for Maryland, we have 16 centers, and in Delaware, we have 3. And for having 3, it may make sense to put 2 states together, right? For patients, Maryland looks small on the map, but there's a lot of people that live in Maryland. So we have over 360,000 patients that we serve in Maryland. And in Delaware, there's over 41,000. I always like to share the kiddos that we serve as relative to those numbers. So in Maryland, of the 362,000 plus, the kids are over 100,000.
Wow.
Delaware, out of the 41,000 plus, it's actually closer to 11,000. It's in Maryland, we have our urban centers and we have our rural centers. We do treat, on average, the 65 plus population that we treat in Maryland is 11.65, so almost 12% or so. But when you go out into our rural areas, it's probably like some of my other colleagues. Sometimes that's the only provider in town, and you'll start to see a lot more Medicare patients. In Delaware, for our older population, it's almost 11%. Medicaid. Let's talk Medicaid, ladies. In Maryland, it is almost half of our population served. So Delaware, a little bit less so. It's a little over 40%. And I already talked about the 65 plus. So I'll skip Medicare. For our third-party payers, that's going to include our commercial insurers and whatnot. In Maryland, it's over 21%. And in Delaware, it's about 16%. And then for our uninsured in Maryland, it's about 19%. And then in Delaware, believe it or not, it's about 38%.
Really?
Yes.
Wow. In such a small state.
It's a small state, and I think, there's not as many insurance products in Delaware. Sometimes our payment adequacy from commercial insurance is very challenged in Delaware. So there's a lot of different things going on. I think Also interesting and unique to both states is we have a lot of agricultural workers, especially on the Eastern Shore. We have poultry farms, so I think, with those jobs, you also have a lot of uninsured folks. But yeah, I think, probably one of the most important data points that I always mention when I'm sharing our stats is what percent of our patient population live at or below 200% of the federal poverty level. And in Maryland, it's over 86%. And in Delaware, it's over 94%. So we're really talking about people that need our help.
Right.
They need us to listen, and they need us to just, help them have better lives at the end of the day.
Yeah. Shelley, talk to us a little bit about your state and what's going on there. How many health centers, and what are some of those gems that you'd like for our listeners to know about?
Absolutely. Thank you so much, Tracy. So with Pennsylvania is a fairly large state whenever it comes to the number of health centers. We actually have 54. And, I'm excited and proud to always say that of those 54 members, all of them are members of PAC, which is really wonderful for me to be able to have the privilege to sit here and say.
Now, Shelley, let me just interrupt you. Now, what is PAC?
PAC is the Pennsylvania Association of Community Health Centers. That is the primary care association for Pennsylvania. So you may hear me say PAC as we go on throughout our discussion, but that is our organization in Pennsylvania that is our primary care association. And, as we talk about those 54 health centers, our Commonwealth is really big in the sense of those 54 health centers serve 1.2 million patients across Pennsylvania.
Wow.
There are over 475 sites. They range from inner city Philadelphia, inner city Pittsburgh to rural Pennsylvania, where that is the only provider. We recently just had an opening in Sullivan County where one of our health centers reopened a center that was closed, that is now the only provider in that county for them. So it's really, a great service that our health centers come together and able to provide. 1 in 13 Pennsylvanians receive their health care from a community health center in Pennsylvania. And it's so important because about 48% of our health center patients are on Medicaid. And, as you introduced the topic, Tracy, with, the passage of the recent bill, Nora mentioned her population, at or below the federal poverty level. It's 88% for community health center patients in Pennsylvania. And when we think about the care that's provided, it's behavioral health care, physical health care, dental care. It really is all those services that, pediatrics, adult, older adult, and the payer sources vary from Medicare, Medicaid, private insurance, as well as the uninsured or the underinsured. And those safety net facilities for our Pennsylvanians are so important in our Commonwealth. We also are one of 4 states in the country that do not provide any financial support to our community health centers. We don't have a line item in our state budget. We've certainly tried to make some inroads with that and are continuing to advocate and legislate for our health centers in that regard. But that does become challenging at times whenever we look at, potential impacts that we might be facing as community health centers within our state.
Great. Thank you, Shelley. Appreciate it. And I want to make sure that I circle back around about that support from your state. But then I also want to talk, ladies, too, and I've made my notes. I do want to touch on a little bit around, again, some of the people that we do see, that your health centers do see. You talked about Medicare. You talked about a large proportion of folks who are at or below the poverty level. But the thing we have to always remember, and I got to remind our listeners this, because we talk about it often on this show, is the fact that even though we may be seeing a population that may be a certain percentage of the poverty level, right? Many of our patients work. Many of our patients have jobs, right? And so these are people who are so committed to their communities, staying healthy, keeping their families healthy, because at the end of the day, they want to keep a roof over their heads, food in their belly, right? And be able to stay in their community and make some positive contributions. So I want to make sure we touch on that. So Ruth, talk to us a little bit about these DC centers here.
Sure. So the DC Primary Care Association, referred to as DC PCA, we see ourselves as the voice and the backbone of the community health center movement in the District of Columbia. And I always like to say a little, like, maybe not known fact of District of Columbia, right? Most, I'm sure, of your listeners know we are the nation's capital. We're not a state. We have about 68.3 square miles. That's about how big.
Oh, really? I didn't know that.
Yes. And even though we have a population about, anywhere 700, 800, daytime population, because we are the nation's capital, goes up over millions of people in the daytime, and have some porous borders with Nora in the Prince George's, Montgomery County area, and even with Virginia in the northern Virginia area. So we see a lot of daily commute there. So 68.3 square miles, where we have over 60 sites that represent a part of our 8 federally qualified health center, and one other community health center that isn't a lookalike, but is a community health center that is actively engaged in similar work. We have we serve about just over 184,000 patients each year, and that's about 1 in 5 DC residents. I know we're going to talk a little bit more about Medicaid and our population and key demographics. Just to give you some high level, about 85% identify as racial or ethnic minorities, and 67% live below 200% of the federal poverty level. We often say there's District of Columbia, and then there's Washington, D.C., the nation's capital, and the two are not always the same.
Interesting. So, Ruth, just expound on that just a little bit for our listeners.
Yeah, absolutely. Again, the nation's capital is such a wonderful place. It's a beautiful city to come and visit and see, but we often don't necessarily see the poverty in our city, and the number of persons who experience homelessness. For example, we serve over 10,000 people that experience homelessness in the District of Columbia. We have 38,000 children who are on Medicaid due to, of course, lower family income. And so when we really think about Washington, D.C. and the nation's capital versus the district, we always talk about as the tale of two cities, where there's so many, chronic diseases that are, not unlike other areas, but they're so compressed in this 68.3 square miles. So.
Yep. And you also have although we all are very proud of all of our health centers in each of our respective states, but I do want to just point out you have a health center in your state that was on the forefront, if you will, of addressing and combating HIV/AIDS, and that's the Whitman Walker Health Center. And at the time, I can remember, because I'm a DC, Maryland native, growing up, it was the clinic that many folks back in the early 80s, that was their only option, was to go to Whitman Walker, and they're still there.
And they're still there.
They're just doing some amazing work. Sherri, talk to us about West Virginia, good old West Virginia.
I feel like we need to cue Country Roads, right? I think that'd be
Exactly. I love that song too.
I think, though it's not technically the state song, it's the state song.
Exactly.
So the West Virginia Primary Care Association, we're the largest organized independent primary care network in the state. Mm-hmm. We serve 34 community health centers in West Virginia, representing over 550 locations, which 250 of those are school-based health centers. We have a very large presence in school-based health. We serve a little over 30%, so over 1 in 3 West Virginians. So we not only serve as the safety net for the 84% that find themselves below the poverty line. I also like to say that people choose to go to a community health center to receive their care. We also have over about 2.5 million patient visits each year. So we really have a tremendous reach across West Virginia. Of course, that spans over 40, 50 years of work, but very proud of the work that our community health centers are doing to live out our mission and vision. We have a very simple vision. We want a healthy West Virginia. I like to say, I know there's all of the jokes and the things that are said, but to me, we're not broken. We're just not finished yet, right? So we're still moving forward, and our data supports that as well. Maybe a couple of fun facts is a report came out about a year and a half ago that identified West Virginia is actually the most rugged state in the country. I think that would surprise most people because of all of our hills and valleys. Now, that also would make sense about all of our issues around broadband and connectivity, right? Broadband doesn't travel up and down mountains and hills, right? It likes a straight line. But nevertheless, we are the most rugged state in the country, and we're also the only state entirely located within the Appalachian region. So that in and unto itself is a culture, and it's one that we're proud of, and we work with it.
We had to cut off for just a few and come back in, and that's because Sherri, who is living in West Virginia, she spoke about broadband and internet access being a challenge. Well, we actually went through that. But I do want to just kind of take a little bit of time around this internet access, ladies, right? So you all talked about how outside of Ruth, and so it'd be really kind of interesting to hear about the DC, right? District of Columbia, and what their challenges are. But we all have multiple health centers that are located in the rural parts of our respective states, right? And this internet thing, right? I just love for you guys just to share. And Nora, if we could start with you, just to share a little bit about what we and our providers have to think about when it comes to internet access. Something as very simple as what we have no issues with.
Sure. And it's such an interesting topic. Sometimes when I'm on the road out visiting certain centers, I know that I'm going to be driving on a lot of back roads, and invariably I'm going to lose my ways. I'm going to lose where I need to go next because I just have lost all connectivity. So I think from the standpoint of how they deliver services, when they can rely on telehealth, and what modality of telehealth. Sometimes phone is going to be better than what they may be able to get with the internet. So I definitely think it can be a challenge, and I think they're probably used to it, but sometimes we get used to things that we shouldn't have to. Yeah. When you think about everything that's going on with technology today, we should be able to overcome some of these things, right?
Yeah. Right. And one of the things, all of us were at a meeting that we all had attended a couple of weeks ago in Rockville, Maryland, where we met with many folks coming out of HHS and HRSA listeners. And you all have heard me talk about HRSA, HRSA, Health Resources Services Administration, which will be changing to MAHA, right? And so that being said, one of the things that we heard as a priority coming out of this administration will be telehealth services, right? So Shelley, I want to kind of hear from you. What did you get from that as far as that's going to be a priority, especially on the medical side? Because we all see where our health centers are on the behavioral health, right, side. We're already using that. But we all know that many of our health centers kind of put the medical telehealth aside, right? How do you think we're going to be able to help our health centers rethink bringing that on again? I'd love to hear from you, Shelley, you've got all these health centers in the state, and I know there are various rural parts in Pennsylvania. What do you think are going to be some of our complications, our struggles, and what do you think it's going to take for us to actually take that message to our health centers and help them get there?
Sure. It's a great question, Tracy, and clearly we heard telehealth will be a priority. It will be a technology intervention to help support care delivery in all of our communities. And I think it's about, when you think about telehealth, it's, to me, having been a clinician also and still am, it's about adoption. It's adoption on the patient side, it's adoption on the provider side, and it's also the technology. And how are we as PCAs supporting that messaging with advocacy, supporting that opportunity with making sure that they've got the best and most current equipment, EHRs? I mean, when you think about, EHRs, and sometimes you think about latency issues. And what I mean by that is, how long does that take for the system to come up or for the provider to get to the next screen? And that has to do with that patient provider interaction and the access to information. And it really is about that satisfaction and quality at the end of the day. And that's something that I think is really important as we think about Medicaid changes, any changes to our organizations, whether they're the PCA, whether they're the health centers. At the end of the day, it's quality outcomes. It's the difference in the lives of the patients that providers went into being providers at all different levels. We at the PCA and those that we serve through the PCA. And those are just tools that we have to help influence and impact the quality of care that's delivered at all of our health centers.
Yep. And Sherri, so speaking of all the hills and valleys, and knowing what we went through with you a few minutes ago,
Yeah.
what do you think is going to be some of the challenges there for our health centers?
Well, about a year ago, we actually embarked on an initiative to expand telehealth access, and that was for medical as well as behavioral health care. We know it will not work in certain areas of the state. However, we're trying to work with local broadband councils and what have you to continue to build out fiber or to use Starlink or what have you to try to increase accessibility. But we are using telehealth backpacks. They're mobile. We're able to move them. We're finding it to be a good use, especially with school-based health. So I agree with my colleague Shelley about its adoption and how we use it, the quality. But I think also from a PCA standpoint, to add to Shelley what you were saying, we also need to think about the policy regulation around the utilization within our states. There's national regulation, but there's also regulation within our state. So we need to make sure as a PCA that we have looked at those pieces, especially around payment in our state. We have championed audio only has to work also with telehealth, right? Like we can't lose parts of that, especially as we know the video won't work everywhere. But we also need to think about, I shared, we recently found out from our MCO partners that, a national organization is now saying telehealth, the utilization of telehealth as the modality of care will no longer close care gaps. It won't count. Well, that's directly against the administration, what they're trying to push forth. So we need to help champion and advocate for alignment in these areas. So I think we can play a big role there.
Ruth, what's going on in telehealth in the district? Are DC folks, I mean, what? Are the health centers as reliant on telehealth services and offering it up to their patients like us and our 4 other states here?
Yeah, certainly, we are very much a pro telehealth jurisdiction. One thing that I will say that, the beautiful 68 square miles is that we at the DC Primary Care Association, we really have been a leader in health information technology, even prior to becoming part of a health center control network. We've been doing this for decades. And in fact, we are our DC Department of Healthcare Finance, which is our Medicaid state agency. We are their preferred digital health partner. So we also, in addition to supporting our federally qualified health centers, we have relationships with the DC Department of Healthcare Finance to help support our home and community-based providers, which are throughout the district. We supported 9 of them to really get up and get moved, get electronic health records to get on our health information exchange. All of it, again, is really important around helping providers really securely share data to improve care coordination and outcomes. And it's really important to us as we have a clinically integrated network, the DC Connected Care Network, where we have 7 federally qualified health centers that are a part of that. clearly, right, there are, when as much data as we have, one of the things that we are working on is around the interoperability of that data as health
Yeah.
centers make choices around the different platforms that they use. But we've been able to really build a very robust health information exchange and use health information technology to be EHR or electronic health records or electronic medical records agnostic. And so that's really been a pro for us at DC Primary Care Association. In fact, we've worked with other primary care associations to help support their health information technology work.
We don't have the time to talk about it, ladies, but we are going to have some folks on a future show to talk about interoperability, because, and you all are shaking your heads, right? To us, it makes a lot of sense, right? For us to ensure that our health centers have that interface with their multiple, right, partners, because after all, that's kind of putting their patient in the center, right? And now they'll be able to get all the different information, all the different touches that were done with their patient. Plus, we can then send that information back out, right, to our partners to say, here's some of the latest medications that they've been on or what we've changed them to, just a whole bunch of different stuff. So as we all know, interoperability is so incredibly important. I do want to kind of move on to this idea of, we know the history of the community health center movement and where it came out of, right? And it was a social justice kind of movement, a vision, right, that came out of the civil rights arena. But it wasn't really civil rights related in some respects. What it was truly about ensuring that everybody had access to healthcare services, right? And I tell everybody that, right? It is truly about you and me, the person down the street, the person that lives in the foothills of West Virginia, that we all have some kind of access to good healthcare services. And we all know the kind of healthcare services that our health centers are providing in our respective states. That being said, even though we know what came out of the movement, right, we also know that we are top-notch healthcare providers, right? We employ our providers. Our providers go to some of the same schools as the providers that go to the Johns Hopkins or the Cyanides out on the West Coast. We are that. So how do you all help with that messaging, right? When you're in certain circles, even though we know a majority of where we're located, especially like in the rural parts of our respective states and like the health centers in the District of Columbia and where they're located, talk to me and talk to our listeners, if you could, please just tell them a little bit about the expertise, the quality, right, that's coming out of your health centers. And then what does that conversation look like for you guys when you're in certain circles? And Ruth, I'm going to start with you, District of Columbia. What does that sound like, look like?
That's really an excellent question. And we have really focused on our messaging to be supported strongly by evidence and data so that we're really clear of our impact, and we're leading with value in our messaging and our relationships, building trust amongst our executive and legislative branch locally, but also federally. In DC, again, you mentioned it earlier, our community health centers serve more than half of the HIV patients in the District of Columbia. And part of that is the history of the Whitman Walker Health and its advocacy around persons who are living with HIV and AIDS. We also have very strong partnerships with our local health department to do set patient navigators in our community health centers to do screenings around colorectal cancer, around cervical cancer, around depression, et cetera. We have We have also higher outcomes around for our patients who have hypertension and diabetes and other types of chronic diseases. And so these kind of outcomes, something that I'm really passionate about as I'm married to a veteran, is that we have almost 1,000 patients who are veterans who seek our support in our community health centers, and we proudly serve all. And I'm especially always proud of our work with veterans. And I think, again, that is the movement. This is who we are. This is who we've been. And it's going to be really important for us to stick to the core values of who we are as community health centers in serving all with this comprehensive care to ensure not only that they get high quality, but again, as you said, that they're healthy, productive residents in their communities, that they're contributors, not only our workers, but our patients, to the economic vitality of their communities, of their households and their communities. And that really does help drive from our perspective at the heart of the work that we do.
Nora.
Sure. This is one of my favorite questions because I get to brag about all the amazing innovation that is going on in our centers. Well, one thing I like to say is, the way our centers were already having food as medicine programs, many of our centers had nutritionists embedded. The team-based care approach to make sure that when we have an uncontrolled diabetic patient or a heart patient, a provider can pass that patient off and go work with our clinical pharmacists for like an intensive 2 weeks.
Wow.
We're going to get this patient under control. I forgot to bring my stats of how many patients with high blood pressure are controlled, as well as our diabetic patients. Mm-hmm. And it's one of the things I'm most proud about. It's amazing. And then I think, and this is piggybacking off of some of the things that Ruth said, but really having point of care testing. When our patients come to us, they may have 2 or 3 jobs. We can't send them back away to say, oh, go get your blood work done. You get your blood work done here and now, and we can actually read the results and control that chronic condition in such a timely fashion. And then I would say our centers could probably teach courses to other providers of
totally agree.
How do you close care gaps? I'm going to tell you the data I use. I'm going to tell you how I call the patient and figure out what is the barrier from them coming in to see us to fix this.
Yep.
And, if I say anything else today, we are the place where we can give the best care in the most cost-efficient way, and we're saving total healthcare dollars. So why not? Yep. The other innovation that I'm so excited about, this is new, but many of our centers are embarking on specialty consults, where if you can't get to a dermatologist, I'm going to have my provider call up a virtual consult to that doctor, and we're going to be able to give you care right then and there. Yep. So I just cannot tell you how excited I am to see our centers lead how you fix healthcare. And I just think I'm so excited to see what's to come.
I love that. We're calling it e-consults here in Virginia, which is provider-to-provider consult. And it doesn't mean that the patient might not go to a specialist, but at least it gives that provider, our providers in our health centers, that opportunity to have that conversation first, right, with that specialist. Because really, 9 times out of 10, listeners, if you think about it, who's really managing your health care? Right? It's your primary care provider. And that's who we are at the community health centers. We provide a multitude of services, absolutely, but we start with primary care, right? We start with primary care. And Shelley, you're a clinician by training, right? So, talk a little bit about you expound on what Ruth and Nora are talking about.
Yeah, thanks, Tracy. I would love to, and so glad that Ruth and Nora brought up what they did. And when you think about it, Nora, I think you hit the nail on the head. I mean, we provide the healthcare home for our patients. Our patients don't have the ability sometimes to take 2 and 3 days off of work or a full day off of work. So when they come to our health centers, they can have their medical visit, their dental visit, their behavioral health visit. They can see those providers that are in those locations or co-located to be able to have that efficiency of care. And one of the things that I think we haven't touched on yet that I want to bring up is, We have 3 teaching health centers for graduate medical education in the state of Pennsylvania. And that's so important. And the reason I bring up our teaching health centers, and we've got them in the western part, Philadelphia region, and up towards the Scranton area, these programs are meant to help grow the healthcare workforce in their communities. And the program really aims to increase the physicians and dentists that are trained in community-based settings. They look at how to improve the outcomes of patients that are in underserved communities and really expand the care and access in these rural areas. And part of what we think about, and I think about, as a PCA leader, as a clinician, as that advocate for our health centers, is healthcare is an economic engine in so many of our areas. It doesn't matter if it's rural or urban. Good healthcare brings businesses into the area and keeps businesses in the area. Our health centers are excellent providers and stewards of that great, efficient, economic driver. And they provide efficient and great quality healthcare. And I think that's really important when we think about the expertise that are there. Right. We've got healthcare physicians, providers, staff that they've been there for 10, 15, 20, 30 years. Yep. It's their passion. It's their calling. So I'll kind of pause there because I could get on the soapbox and I don't want to go there.
I know. Me too. Sherri, so talk to us a little bit about this kind of, expounding it from a West Virginia perspective. I love the fact that you guys have so many school-based health centers. And see, people don't really know that we're in schools too. That's right. We have primary care providers and mental health providers in the schools.
100%. And that is such an area. We actually just had a school-based health conference about 3 weeks ago. And it's amazing to me how many within our state leadership are still just learning about our school-based health centers. Yep. Right. And so it's really the opportunity to make an impact in people's lives, right? We lead with value, we lead with impact. And we like to say we're doing the work and our data shows it, right? So we can show you our clinical measures, and we are ahead of state averages in diabetes, in high blood pressure, in these other areas. I think that the opportunity to show the impact, we have the data in front of us, and when we are able to show stakeholders and legislators, they always take a pause because again, we do talk in terms of we're doing the work. Yeah. So, and I agree with Nora this is, I think for us, isn't this some of the fun part of our job? Because we are, we're really good at putting our heads down and working. But when we do have that opportunity to shine the light on the health center's work, it's just a special part of what we get to do. And we are showing that we're changing lives. It's systemic changes happening, patient by patient, community by community. And so I think that's something that's our job. Right. As PCA leaders, that's part of our job, is to really continue to show the efficacy of this system of care.
Totally agree. And one of the things that I always said when I started and I got into my role at the Virginia PCA was that I had told our health centers, look, guys, you are doing some amazing work out here, and you've done it for years, and you're ingrained in the community, and the community really, quite frankly, would have a tremendous, it would be a tremendous loss if there was no community health center in the communities that we serve. So show it off. Show off. You could go to the federal website and pull up the data and all that. But what's wrong with letting folks know how well you're taking care of them by putting the information in your waiting rooms, or, putting it in your consult rooms or on your website for that matter? Show off the work that you're doing, because what you're doing is what a lot of other providers are out here doing as well. I want to kind of take you all, as we close out our show, I do want to just focus on 2 other areas for our listeners. And that really is around your leadership. It was so important that I brought you 4 ladies to the table because, one, yes, I've worked with you, but I just, again, it's about the show off, right? It's about the show off. And I have to say, listeners, we really do have a treat here with these women. And that being said, I want to ask you all this question. As a leader, and given some of the challenges now that we're facing, what keeps you going, doing what you do? Sherri, you've been in that seat for a while. You've been at that PCA for a while. Shelley, you're just now coming in. You're a year in. We don't call you the baby anymore. Ruth and Nora, Ruth, you kind of came a little bit past Nora and I. Why do what you're doing? Tell the listeners why do what you're doing. And then after that, how do you keep your staff encouraged? And how do you keep your members encouraged? Sherri, can we hear from you on this?
Sure. So first of all, I very much subscribe to the servant leadership model. And that is something, again, that is core, that aligns with my core beliefs. So with that, and I actually share that with our health centers, and I share that with my team as we orient to one another, so they understand the lens in which I view things is always through that model. I very much, to quote the great Vince Lombardi, he was a football coach, if you're not familiar, but, and I'm paraphrasing, but I very much believe in excellence, right? I do not believe in perfection. There is no such thing. Yeah. But I do believe while we chase perfection, we're going to achieve excellence. And I think that is something that sets us apart, is us chasing that excellence and how we are constantly doing quality improvement with the health centers, within our PCA, right? So we remain relevant and timely and give our health centers what they need. In this time that we're in, I believe that we have to have discipline to have calm under pressure. And so we can make thoughtful responses. We're responding thoughtfully. And so we're not reacting chaotically and adding to the noise of the moment. I think that's our job. And so we have to have presence in this moment. And again, to me, it's a discipline of calmness. Now, I know, and especially with my colleagues here, we do vent and share with one another. You have to have outlets. But in this moment, I think for our health centers, for our teams, that's how, for me, that's how I'm leading, because we do have to be strategic in this moment and thoughtful about how we continue access for all West Virginians. And so with that, and leading in this moment with our team, I talk with them, right? We have very open dialogue with one another about where we are, how we feel in this moment, but how we're going to move this work forward. Our work isn't finished, right? It's just, we're going to have to think of different ways of how we now are deploying in our communities, but our work will continue.
Thank you. Nora.
Sure. So I'll start with my why, because it ties into how I try to motivate my staff every day. But my why I still remain and do what I do and do what I love every day is, I don't know if I ever shared with you all, but I became pregnant when I was in college. And I was a young mom, but when I was seeking out OB care, I was not like the other moms that were being treated. I didn't have a partner going in with me. I looked a lot younger than I was even then.
Right.
And I was trying to figure out stuff on my own, because I don't think the doctor ever wanted to say, well, how are you doing? I think they were scared of the answer. And so it was just very transactional. And what happened over time is I was a big Diet Coke drinker. And I'm like, wait a second. This is back in the 1980s. I'm like, aspartame can hurt my baby, so I'm not going to drink Diet Coke. I'm going to drink sugary Coke every morning, because I was still in college. I was still working, and I was still doing the Army National Guard, and I was tired.
Wow.
So a full-time pregnant person. And then I also thought it was healthy if I started drinking orange juice, because I was living on campus. So I was drinking sugar, and I gained so much weight. I ended up having gestational diabetes. I ended up giving birth to a toddler because he almost weighed 11 pounds. And I know to this day that if I was in the care of any of my community health centers, it could be Dr. Mozella Williams up at West Cecil. It could be Dr. Ursula McClimate at BMS. It could be Dr. Marseille White at Total Healthcare. They would have all saw me come in and say, how are you doing, Nora? And that's all it would have taken for me to say, hey, I'm really tired. I'm trying these tricks. But instead, I'll end the story there. It all ended up okay. But after 3 C-sections later, as you can imagine. But that combined with one of my favorite quotes, and it's probably some of yours too, just by me knowing you all, is Maya Angelou's. People will forget what you said. People will forget what you did, but they'll never forget how you made them feel.
Yeah.
And I tried to, that doctor made me feel a certain way. And then the doctors that I'm privileged to support every day, I know would make me feel different.
Right.
Why I do what I do. But then with my team, I see them come in on days and maybe they're having a bad day. Maybe they're struggling with something. And even if I'm hyper about getting the work done, I try to take a step back and say, okay, these are human beings. How are they feeling today? And just keep that top of mind. But thank you for indulging my story. And
I love it. Thank you for sharing.
Yes.
Ruth.
Sure, thank you. That is so amazing, like you said, just to be amongst you all and just your journeys.
See why I had to have you all on the show?
Exactly.
Okay.
This is so inspirational for me, and I'm certainly sure for your listeners. I would certainly say for me that it has always been, I view my vocation as a calling. And so my leadership approach is aligned. For me, it's about how do I lead with purpose, not my position. And so in that calling, it's always going to be rooted in that service and that service leadership we talked about, in integrity and in community. And so from that perspective, for me, it's always like I delight in, even though I'm an introvert, I delight in being able to empower.
You're an introvert?
Oh my gosh. So introverted. I really am. I retreat in my little spaces and I get my energy from that kind of retreat. But I've been so wonderfully blessed with community that, helps support me and authentically who I am.
Yeah.
And again, I seek to cascade that and lead in that kind of perspective with my team members. I collaborate with my communication leader, and we came up with this opportunity for me to share my heart again, because, some of, my introvert is that I can kind of withdraw, for me to share my heart. So every 2 weeks, I sent out what I call a CEO corner, and it's only to my staff, and I share just like a heart. Share my heart with each of them, and then we have opportunities to spotlight leaders. And for me, that again, I share how things in my life that things that keep me up at night, including what we're dealing with in our advocacy and policy spaces. I'm really authentic with them so that they recognize I'm human. I'm human. I make mistakes. We drive together, we succeed together, and we regroup together. So those are kind of things that really drive me around, values driven, around empowering others, and of course, always acting with accountability and me leading in that.
Awesome. Shelley.
Thank you so much. Boy, these are tough acts to follow. with these
Tell me
ladies.
about it.
Just such an honor to be in everybody's presence. What I will say is, as a young nurse early in my career, I went into behavioral health. And I spent a lot of years in that field. And that is a field that is often misunderstood. And this was in the early 90s. And, I think for me, my journey in healthcare, my journey in leadership has been about perseverance. It's about drive. It's about compassion. It's about bringing things into the light with integrity and leaning into that. And I would say, as I've developed and gone on through my career, a transparent leadership and an honest leadership style is what I approach it with. And what I've been able to be successful at, and hopefully we continue to be successful at and leverage all of our strengths, is that transformational leadership with integrity and thoughtfulness. Being that steady calm in the presence of uncertainty, I think is so important for all of us right now. And, having that support system and talking with one another, those are just such key. They're not just words for me. They're kind of my marching orders, and what the little thing is on my shoulder sometimes. And Nora, I love the Maya Angelou quote, because that is something that I truly believe in, because to this day, I think what folks remember is how we've made them feel. It's not exactly what we've done. And that's why I think a lot of us have folks that we've worked with in other areas that we've been in, that follow us to the next place where we've followed them. And those are just so that speaks so highly of leadership qualities and traits. So, just honored to be among you guys, and, not the baby anymore, or maybe still the baby, but,
Right.
it's always great to have the wisdom among the group.
Well, I so feel the same way, ladies. And after having our time together this last hour with you and talking about all the different things that are going on in our world and our sharing with my listeners here, I have to say, being amongst you all and listeners, we are what they call the Region 3, is how the feds break us up. So it's Virginia, it's Pennsylvania, it's DC, it's Maryland and Delaware, and it's West Virginia, listeners. That being said, I have to say, being in this group and being a part of this particular Region 3 group, it takes me to a quote that I used to always hear when I was living up in the Maryland, DC area. Growing up, I would take this and it's always stuck with me on my journey, professionally as well as personally. But it was always said by Donnie Simpson when he would finish out his segment on W 93.9, right?
Yeah.
He would say, right, when he was signing off, he would say, always try and shoot for the moon. And if you don't succeed, you'll be among the stars. And right now, I am among the stars. So Thank you, ladies. I appreciate your time. And I'm so looking forward to continuing to work with you. I want to thank my guests for joining me today. And thank you to all the listeners for tuning in to CommonHealth, brought to you by the Virginia Community Healthcare Association. If you enjoyed this episode and you'd like to help support CommonHealth, I encourage you to hit subscribe button and share it with others on social media. Leave a rating and review or visit our website at www.vcha.org. This is Tracy Douglas, and thank you again, and I'll see you next time.